The knee, I like to say, is a complex hinge. And for many reasons, it can wear out, either through just time, wear and tear, which is called osteoarthritis, or after trauma, or prior surgery, or infection, or deformity. When the cartilage or the soft cushion, which we are all issued, wears out, and the bone starts to rub on the bone, we can tell on exam, we can tell by the patient's complaints of swelling and pain and stiffness, that along with an x-ray can tell us that there's arthritis in the knee. In the 80s, this technology of knee replacement became very popular to actually put a metal and plastic part in the knee to shave off, if you will, those worn out parts on the end of the thigh bone or the femur and at the end of the shin bone where that bone met. And so by using prostheses, which we call our implants, and either cementing or fixing them to bone in other ways, we can replace the worn out parts. So it really is a replacing of the end of the thigh bone with a metal implant, replacing the end of the shin bone with a metal implant, and then a plastic insert that serves as an artificial meniscus, and usually a plastic insert behind the kneecap. So those are the articulating surfaces that are replaced, and that's called a knee replacement. Knee replacement surgery's come a long way. We talked a little bit about the length of the incision and controlling bleeding. I would re-emphasize that it's not the length of the incision, but a number of factors that lead to a minimally invasive procedure, to quicker recovery, quicker motion, less bleeding. But minimally invasive usually means using as short of an incision as possible. I always tell my patients, you want me to see what I'm doing, so you don't try and operate through a keyhole. But clearly we're able to do this through smaller incisions and with less bleeding. And there's a large tendon inside the knee called the quadriceps tendon, which in traditional knee replacement may need to be cut or split for long distances. Well, in today's surgery, we're able to work around that and split some of the muscles as opposed to cut some of the tendons. And that allows for quicker motion, better strength, less bleeding, and quicker recovery. So that, along with the instrumentation, which has gotten more clever or smaller or allow us to work through smaller holes, along with the pain management pathways that we use, have allowed for smaller incision and quicker recovery. So that would be called minimally invasive knee replacement.